Okay, great. So that minute went quicker than I thought, but we'll get started. So today's webinar will specifically highlight the vital roles and complex tasks undertaken by family caregivers in supporting individuals undergoing cell transplantation and CAR-T therapy. We will also be exploring the profound impact of this work alongside crucial resources designed to address family caregivers' education, training, and support needs. So I'm going to get started. I'm going to get us started by sharing information about the National Alliance for Caregiving. My colleague Melina will be sharing information about our work with and for transplant caregivers. And you will also be hearing from Dr. Hannah Abrams from Fred Hutchinson about her research on this topic, as well as Sue from BMT InfoNet, who will share their resources and supports for family caregivers. And we do have a designated time at the end for Q&A, so I ask that you hold on to your questions until the end. And then when that time comes, I'll ask you to type in your questions into the chat feature, and I will be moderating that conversation. So first, to get us started, the National Alliance for Caregiving has been a catalyst for change, transforming how family caregivers are recognized as supported and valued in this country. There are currently 53 millions providing complex care, and our work is to conduct research and advocacy efforts to drive policy, system, and culture change needed to make family caregivers a national priority. With more than over 50 members, we build partnerships across aging, disability, healthcare, philanthropy, and the private sector to make caregiving more sustainable, equitable, and dignified. Here you see our three organizational priorities: champion caregiver health and wellness, promoting caregiver financial well-being, and fostering caregiver-friendly communities. As NAC's Programs Director, I lead our cross-sector partnerships, which aim to enhance the recognition, inclusion, and support of family caregivers within the healthcare system. There are currently 53 million family caregivers who are providing critical ongoing care to family members or friends living with serious illness, disability, or needs due to aging. This figure underscores the immense scale and the essential nature of family caregiving in our society. Family caregivers are the unseen backbone of our healthcare system. Their tireless efforts are often overlooked, yet they provide essential support in the diagnosis, treatment, and ongoing management of serious illnesses like cancer. And in the case of transplantation, having a caregiver is often a requirement in order to receive this life-saving procedure. These caregivers are truly performing complex medical and nursing tasks at home, often without inadequate training. Think about it. They're administering injections, managing complex medication schedules, performing wound care, and constantly monitoring vital symptoms. Our research at NAC shows that, in fact, 7 in 10 cancer caregivers are performing these critical medical and nursing tasks, often without formal training. The toll on caregivers is immense. We see that they face substantial emotional and physical stress, leading to things like anxiety and depression, and many are literally neglecting their own health as they prioritize the needs of the persons they are caring for. Caregiving is also not just emotionally draining, but financially devastating for families. Caregivers are often managing overwhelmingly medical costs and non-medical costs associated with being and needing to be in the healthcare system. Many are forced to reduce their work hours or leave their jobs entirely, directly impacting their household income and access to health insurance. And yet, despite this critical role, caregivers often consistently report major gaps in the support, education, and training. Critically, they need practical hands-on training for the medical tasks that they are expected to perform, as well as guidance and support on navigating the complex and fragmented healthcare system. These themes really underscore the necessity for comprehensive support systems that acknowledge and address the multifaceted challenges faced by family caregivers in chronic and critical illness situations. To address some of these, to begin to address some of these needs, NAC launched, the National Alliance for Caregiving, NAC launched a cancer caregiving collaborative last summer. The collaborative's executive and steering committee are comprised of individuals and organizational members representing patient advocacy, industry, research, healthcare, and family caregivers. And I really encourage you to visit our collaborative website to learn more information about our partners or work and hear from caregivers about what it's like to care for someone with cancer. The collaborative focuses on two main priorities: championing caregivers who care for someone by promoting reimbursement pathways to increase access to high quality training, educational resources, and support services. Essentially, how do we better integrate family caregivers into care teams? And the second one is focused on addressing the financial toxicity of cancer caregiving by advocating for smart, and equitable economic policies. Moving on to our transplant caregiving collaborative, it is also comprised of diverse stakeholders who are actively working to elevate the recognition and support of family caregivers within the transplant system. One of the things that's unique about our collaborative is that it bridges this historical divide between solid and non-solid organ transplant communities, bringing them together to address the experience and the needs of family caregivers and patients. Over the past 2 years, we've published 2 key reports documenting the needs and experiences of transplant caregivers, as well as issued recommendations about how we can better enhance support for family caregivers. My colleague Melina will talk a little bit more about these findings and these recommendations shortly. And again, I encourage you to visit the Transplant Collaborative website, which she has shared through the chat, to learn more about her work and hear compelling stories directly from family caregivers in transplant care. With the Transplant Caregiving Collaborative, our focus is on critical priorities that drive significant improvements within transplant centers. We aim to strengthen support for family caregivers and champion essential reforms across the entire transplant system. We do this, we have 3 main strategies: peer learning and resource sharing, which is part of the reason for this webinar, and we have a whole schedule for the year. Policy and advocacy, we encourage you to sign up for a listserv so that you can get updates and actionable insights and that would enable you to take action on both of these issues. And then storytelling. We believe in the power of narratives to foster connection and understanding and ensuring that caregiver voices are heard and amplified. So we'll be collecting additional stories and hosting listening sessions in the fall. So with that, I want to turn it over to Melina, who is going to talk more about our transplant caregiving work.
Hello, everyone, and thank you, Adara. So yes, I'm going to take the next few minutes to briefly go over our 2 recent reports. In 2023, we released Transplant Caregiving in the U.S., a call for systems change. This report set out to better understand the transplant caregiver experience and identify where the system is falling short. So it drew on a broad foundation. There was a literature review of 81 academic journals, a panel with 10 subject matter experts, focus groups with 30 caregivers, and in-depth oral histories with 12 caregivers. And the findings were very clear. Caregivers are not just part of the transplant journey, they're often a prerequisite for treatment, yet they face high emotional stress, minimum preparation, limited recognition, and serious financial strain. The report identified factors that contribute to caregiver access. It identified that there's no consistent process for caregiver screening or assessment. There's a lack of coordination and follow-up across transplant centers. There's not adequate financial protection or logistical support. There's an absence of formal caregiver training and education, and there's no standard method for collecting caregiver data or evaluating outcomes. And all of this contributes to a widespread lack of support that leaves caregivers feeling isolated and overwhelmed. And sadly, we know that there's a burden of transplant caregiving isn't equal. And across different socioeconomic and diverse racial and ethnic backgrounds, you see the inequities. And you can use the QR code on this slide to see the full report. And I encourage you to read it because there's so much information. As I said, the report had caregiver stories, and I want to ground a little bit the conversation and illustrate the day-to-day realities of caregivers. So we have Maggie here, who's a BMT caregiver, and she cared for her son. And part of what she said is that the hospital provided a 1 to 2 hour training. It focused more on how to take care of them and very little on how I would be supported. And on a personal level, I was a formal solid organ transplant caregiver. And this quote really resonated with me. I remember going through transplant education, a 30-minute nutrition session, and a quick social worker meeting, and I was all in the same day. And at no point was I, the caregiver, acknowledged or assessed to ensure that I had the tools that I needed to care for my loved one. And then another quote, this one's from Nancy. She's a stem cell transplant caregiver for her husband. She said that the hardest part of for me is that you really do become a tech in a way. He had a port and I had to deal with the dosage, the medications, and it wasn't easy. And this quote reminded me of another one, but this was from a cancer caregiver. And she said, I didn't realize I was being trained to be a nurse. I thought it was backup. And it just really highlights the complexities of caregiving, how you're sometimes thrown into these medical tasks without all the support that you need. And it's just a snapshot of what many caregivers are facing. In our research, it shows that there's challenges and there's a lot of systemic gaps as well. Which brings me to our second study, which is gaps and opportunities, family caregivers, and U.S. transplant systems. This report was released last fall, and we partner with Cole's Group as well as an advisory committee of caregivers, researchers, clinicians, and advocates. And we were able to survey 114 transplant centers nationally, and it included BMT and stem cell ones. And it was completed by transplant center directors and support staff. We assessed 3 different areas, caregiver assessments, support and service delivery, and education and training. And before I go into the findings, I will provide some definitions for context. So family caregiver programs was defined as structured, planned, and coordinated activities as part of routine care. So it wasn't pilot programs, it was things that were continuous. And then caregiver needs included understanding medical aspects of transplant, clarity on roles and responsibilities, so think coordination and communication, addressing social determinants of health, and caregiver self-care and wellness. So with that, I'll go a little bit into the findings. So over 40% of centers had no written process for assessing caregiver support needs. So the assessments happened earlier on in the transplant journey. And then if it ever happened again, it was because it was triggered by a crisis, like hospitalization or complications. And only 3% of centers actually conducted routine assessments. 70% offered 2 to 4 structured caregiver programs, but 30% offered nothing. And within the 70% that did offer anything, the type of programming wasn't consistent or the type of delivery wasn't consistent. So it could be a third party or in-system, with in-system referral being the most common. And then with respect to barriers, we were really surprised that 48% were not aware of caregiver needs. After that, it was financial and resource constraints, and then staffing limitations. And then lastly, 58% of centers did offer some type of caregiver-specific training, but there was no standardization among what the trainings were offered. So there was variation in the type and timing of trainings. So I'll share the recommendations. There are 6, and for sake of time, I won't go over all of them, but I will highlight that maybe for BMT and CAR-T, it'd be important to have a care coordinator who could serve as a consistent point of contact throughout the transplant journey. They would be able to answer questions, coordinate support, help caregivers adapt as circumstances evolve. And then I would highlight leveraging the new Medicare billing codes for caregiving training. So those are the CTS codes. They offer a path to fund structured caregiver education. And our report shows that the awareness is high for these codes, but the utilization is low. So maybe promoting broad adaptation of these codes would help improve access to services for caregivers. And I'll pose this question. Please leave your answers in the chat. How can we adapt these strategies and recommendations to better support patients and caregivers in CAR-T and BMT? And with that, I'm going to take a moment and introduce our first speaker. Her name is Dr. Abrams. She's a fellow in hematology and oncology at Fred Hutchinson Cancer Center and the University of Washington. She completed her MD at Baylor College of Medicine in Houston, Texas, followed by internal medicine residency at Massachusetts General Hospital. Her research interests are in implementation in cancer care delivery, in particular for rare cancers, with the goal of reducing the logistical burdens associated with rare cancer care. Her prior work has addressed out-of-pocket costs for families of patients with pediatric cancers, communication and advanced hematologic malignancies, and the logistical and non-medical requirements for HCT and CAR-T therapy. Thank you for joining us, and we're so excited to learn more about your work.
Thank you so much for the introduction, and I'm really grateful to have the opportunity to join NAC and to speak to this group. So I'm excited to share with you my work and some of our thoughts on the landscape and impact of caregiver requirements for hematopoietic cell transplantation, or HCT, and chimeric antigen receptor T cell therapy, or CAR-T, nationally. Oh, excuse me. So to kind of address some of the questions, or to cover this topic, the first question that I want to ask and explain is what HCT and CAR-T are and how caregivers fit in. And I'll say I know that there are numerous experts in the audience here. We'll try and address this from a patient-friendly lens, assuming that not everyone here is an expert in this therapy. Second, I want to talk about the national landscape of caregiver and logistical requirements for HCT and CAR-T. And this is work that we'll share, a survey that we completed, to give you a sense of what the current state is and connect to some of those recommendations that Melina shared. Lastly, I want to talk about some things that I think are really hopeful future directions in this field, how NMDP and NAC are reimagining caregiver requirements in allogeneic transplant. I want to highlight some future directions. So first, to start, what are HCT and CAR-T? And I'll summarize by saying that these are curative, transformative, or long-term therapies for some cancers, autoimmune diseases, and genetic diseases. And that's quite broad. And I know that Susan will talk more about this in our second talk. I would highlight that, just to give you an example, some of the cancers that we can treat with these therapies include leukemias, such as myeloid leukemia. Autoimmune diseases that we can treat include multiple sclerosis with autologous transplant, or severe aplastic anemia with allogeneic transplant. And genetic diseases include sickle cell disease and beta thalassemia, genetic diseases that affect the blood-making or hematopoietic system. And I'll say one of the things that's really humbling about going to medical school is I very rapidly became someone who was not very intelligible to used a lot of jargon, not very intelligible to people who had not also gone to medical school. And so I want to check that a little bit here and talk about the alphabet soup, the variety of acronyms that you may hear today, or that you may hear as you look into this topic. And so I'm going to use the term hematopoietic cell transplantation that you can see here. Other terms you might hear: peripheral blood stem cell transplant, hematopoietic stem cell, bone marrow transplant, you may see. And I'm going to use the term HCT for two reasons. One is I think it's the broadest term. So hemato meaning blood making, or hemato meaning blood, poetic meaning to create. So it's kind of literally describing that concept. And two is that I find that many patients, students, potential donors have the misconception that oftentimes we're taking bone marrow directly from the bones to complete a transplant. And that's actually not very common, or not as common in the modern era. Most commonly, we're doing a peripheral blood transplant where cells are mobilized using medication out into the blood, and then we take those cells out through a big IV, a procedure called apheresis. And so I'll use the term HCT here. You may hear me slip and say stem cell transplant, but those, for the purposes of this general talk, I would say you should consider these terms as similar. Next, I'm going to explain some terms that are not similar and that I do want you to be able to distinguish between to understand the role of caregivers. So the first is autologous stem cell transplant. And I'm going to go through the three modalities that we're talking about today: autologous transplant, allogeneic transplant, and CAR-T, each in a row as we talk about each of them. So in an autologous transplant, the issue is outside the bone marrow. You can see the ribbons here are for myeloma, lymphoma, and testicular cancer. So these are issues that don't directly come from the blood-making system. And oftentimes when I'm talking to students, I actually just say, take the term autologous transplant, take the transplant part of it out of your mind. Instead, think about really high-dose chemotherapy with a stem cell rescue. So these are problems that can be treated with chemotherapy. And so what we do is we take the stem cells from a patient's own blood system. That's the apheresis graphic you can see here. And then we give chemotherapy, and we return the stem cells back to them and wait for them to engraft or come back and essentially set back up with the in their blood-making capacity. That process, the process of having very low blood counts due to the chemotherapy before the cells come back or engraft, can take between 10 and 14 days, longer or shorter depending on the patient, or usually longer if it's within this range. During that time, you can see patients have a very low immune system function, blood counts are low, and platelets are low. So at many centers, patients are hospitalized during this entire procedure, or during this entire very low blood count period before what we call engraftment, or blood counts coming back. But at some centers, this can be done outpatient through very frequent visits to the medical center for transfusions, et cetera. Patients are also on antibiotics to prevent infection. Allogeneic transplant, by comparison, and again, kind of just giving a broad overview here, the issue arises in the blood-making system itself. So the example kind of classically would be myeloid leukemia, in which there's a cancer of the blood-making system itself. So we can't, if there's a cancer in the blood-making system itself, we can't give back someone's own cells because that's where the issue is. And so instead, we give cells from someone else. So we give chemotherapy. We then give someone else's cells, so cells derived from a donor. Then there's a period until engraftment, similar to auto, between 3 and 4 weeks, often, in which patients have very low blood counts, need antibiotics, monitoring for infections, and blood transfusions. Then for another 30 to 60 days, patients are at risk for a condition called acute graft versus host disease. And I know Susan will talk about acute and chronic graft versus host disease later. I'll just summarize by saying these are autoimmune conditions somewhat, or similar to an autoimmune condition, but instead, this is the graft, meaning the cells, attacking the patient, the recipient of the cells, which it sees as essentially a not self antigen, or seeing as not self. I'll contrast all of that with our last modality that we're going to talk about today, which is CAR-T cells, or TCRs. It's a group of engineered T cells. And these also, similar to an auto transplant, address something that's happening outside of the bone marrow. So these ribbons are for lymphoma, myeloma, and sarcoma, which is the first approved TCR for solid tumors. And what we do is we use apheresis again to take T cells out of the patient, and then manufacturer, private companies engineer these T cells in order to attack something that we know is on the surface of the cancer. We then give chemotherapy to kind of clear out a niche for the T cells and reinfuse the T cells back. You can see the graph on the bottom looks different. The big risks of this, if you think about we're training the T cells to go activate the immune system against something we know is in the body because we know the cancer is there, the big risk essentially comes from the activation of the immune system. And so what people can experience, I've kind of given you some icons here to demonstrate. We talk about cytokine storm or cytokine release syndrome. So these are the signals that the body sends. This can essentially look like sepsis with very high blood pressure, or excuse me, low blood pressure, high heart rate, or high fevers. Again, looking like someone who is seriously infected, or neurologic toxicity, what we abbreviate as ICANS, in which patients can become confused or when very severe have seizures, etc. The period of risk for this is greatest toward the beginning, but oftentimes we think about this risk period as lasting for about 4 weeks. So just to summarize both of those, and then we'll talk a little bit about the caregiver component and where caregivers fit in. Auto transplant, the major risk is infection from low blood counts. The highest risk is in the first month. Allogeneic transplant, major risks are infection and graft versus host disease. Big risks in the first 0 to 100 days for acute graft versus host. And then CAR-T cell therapy, risks are cytokine release, brain toxicity, and overall effects of high levels of inflammation. Again, just very broadly summarizing, risks in the about the first month. Okay, so what are the caregivers doing in all of this? And I know there are, many folks in this room who are exceptionally well-versed in what caregivers do during this process. I would say that during a 25-minute talk, it probably would have been easier for me to tell you what the caregivers aren't doing during this process. Every time I work with caregivers or talk with caregivers of patients who are going through these procedures, I am amazed by how much they are doing. Just to give you some examples, and these are drawn from both personal experience and by a fantastic publication called Can You Spare 100 Days from the NMDP. Caregivers are monitoring patients for fever. Melina mentioned this as well. Doing meal prep and encouragement, especially for those who have just gotten chemotherapy, may have mucositis or inflammation in the mouth that makes it really hard to eat. Providing emotional support, transportation to and from appointments, especially those daily long appointments for those who are doing outpatient-only therapy. For people going through CAR-T, blood pressure and symptom checks, cleaning the home, making sure that things are sanitary and safe while the immune system is exceptionally low. Providing complex medication management, so similar to solid organ transplant for those who are in the room. Our transplant patients are on quite an extensive med list during transplant, and providing financial support, childcare, participating in other caregiving asks and requirements that their care recipients are not able to do while they are undergoing transplant. So caregivers are doing a ton. They are crucial. So all of this, the group of physicians that I worked with, to put together this survey, we had all seen patients who had not been able to get a transplant because of lack of a caregiver or because of other logistical and non-medical requirements, things like citizenship status, transportation, lack of local housing. So all of these things, we had seen people not be able to get a transplant because of these things. And we know that caregivers in particular are really crucial. And so we wanted to conduct a survey to understand what caregiver requirements are nationally, to understand what supports are available at different institutions, whether processes are standardized, and what barriers program leaders think are most important. And I'll say this really ties directly into the priorities and recommendations that Melina presented, that NAC put into their transplant requirement, or their transplant caregiver report. Talking about recommendation number 1 was to talk about standardization of these processes. And we really wanted to basically take the first step and understand even how much tracking is there of these. And then other recommendations related to support and related to sharing data between organizations and centers. So this is kind of a first step to those things. So just to briefly explain the survey that we completed, again, I know there's a lot of researchers in the room as well, but we surveyed through the NCCN, which is the National Comprehensive Cancer Center Network, which is a network of 34 leading cancer centers, largely academic across the United States. These centers create guidelines for cancer care, which are used worldwide. So the NCCN guidelines. The network also has a best practices committee, which is composed of physician, nursing, and administrative leaders from each institution. That essentially the goal is really to share best practices across institutions. So we thought this was a good home for some of these questions where really we don't know what the national landscape of best practices is. We don't know how much sharing is going on already. We completed the survey between July and August of 2024. We got 91% of responses, so 31 responding centers. And those centers in total that responded represent over 40% of national bone marrow or hematopoietic cell transplant volume. And we don't have numbers nationally for CAR-T. These are numbers published by the CIBMTR, but we would imagine it would be a similar national representation of CAR-T volume. So for the next few slides, I'm going to walk you through what we found for autologous transplant, allogeneic transplant, and CAR-T. I'm going to focus here on caregiver requirements and some of the stuff that's most directly related to caregiver requirements. I'll say we surveyed on a variety of things as well, including drug use, medication adherence, citizenship status. Some of these soft or informal contraindications that we have seen in practice can affect access to care. So for caregiver requirements for autologous transplant, so cells coming from the self, really high dose chemotherapy with a stem cell rescue. The large majority of centers, unsurprisingly, require a 24/7 caregiver during care. We actually asked how many hours a day do you require a caregiver? And literally, if you require one, every center said 24. So just to give you a sense there. 84% of centers require a caregiver for auto. The large majority do allow for rotating caregivers, which is a big source of relief for family caregivers especially. But almost 20% of centers don't allow paid caregivers. Few centers are able to provide what we called an inpatient option for the supportive care phase. And what we mean by that, what we ask them is if the patient would otherwise be outpatient, but they don't have a caregiver, are you able to keep them inpatient for longer than you would have otherwise, or hospitalize them when you wouldn't otherwise, to bridge for that lack of a caregiver? So 30% of centers are doing that, again, speaking to the economic and health systems value that caregivers are providing to our patients. Very few centers are able to assist with caregiver cost, and probably that also includes some combination of concern about inducement to the procedure by providing cost, though it's certainly really challenging and makes this an even more stringent barrier. Showing you for allogeneic transplant, unsurprisingly to us, 97% of centers, all but one center, required a 24/7 caregiver during therapy. Rotating caregivers were allowed for almost everyone. Again, a pretty sizable 30% of centers not allowing paid caregivers. 23% allowed an inpatient option or extended inpatient option where otherwise it would not be, which makes sense. These are longer hospitalizations, longer low blood counts, and very few centers are able to assist with cost. Lastly, for CAR-T, 100% of centers required a caregiver. Rotating caregivers were allowed by most, and paid caregivers were allowed by 81%. And then, again, a small minority of centers allowed for an inpatient option for the supportive care phase. And just to respond to the question from Dr. Gray, I saw in the chat that this is supported by this is published. We presented this at the ASTCT, the American Society for Transplant and Cell Therapy meeting in February, and we will be publishing this hopefully soon. Here, to me, was one of the most striking differences across caregiver days that were required, or across institutions, really. So this is a histogram. At the bottom shows the number of days, and at the top, or the vertical axis, shows the number of institutions. This is a histogram of how many days a center requires a caregiver nationally if they do require a caregiver, which again is the large majority. And so you can see for autologous transplant, essentially the same procedure, the range is from 14 to 110 days that are required for a similar procedure. And that's a pretty big ask, again, speaking to that NMDP publication. Asking someone, can you take off of work and be my 24/7 caregiver for 100 days is really challenging to ask of caregivers and makes it a higher barrier. By comparison, 14 days sometimes easier to do, though again, these caregivers still have significant requirements. And then what happens if there's uncertainty about a patient's not doing as well as we might have hoped and they still need care beyond that 14 days? For allo transplant, I'll highlight again the difference is quite broad. these two institutions at the very bottom, probably that's a little bit of a miscount. We'll clarify that a bit more in the publication, but those also include the hospitalization. But broadly, the range is between about 50 and 110 days. So quite a lot of variation between centers. For CAR-T, most centers cluster around 1 month or 4 weeks. And then the range is between 14 and 56 days. So quite a lot of variation nationally between what we're asking of caregivers and how we support them. Not the focus of this talk, but I do want to talk briefly about local housing requirements. So again, think about not only are caregivers providing 24/7 care, but if you live 60 minutes from your center, sometimes that means you're also moving to a new place. And sometimes that also disconnects from other support, other caregivers, the caregiver network can make it really challenging. So we found that centers had distance requirements. Those requirements were anywhere from 30 minutes to 120 minutes to keep patients within kind of a safe distance so that if they became acutely ill, they could come in immediately. And the range of the amount of time that we expect caregivers and patients to stay in that area, again, is quite broad. So looking at auto again, from under 2 weeks or 2 weeks or less to 100 days. So quite a lot of variation nationally. We did survey also about, again, just to speak to what is in the economic and emotional and all of these supports that are going into supporting patients. Local transportation is a requirement for almost everyone. Insurance access can be a huge barrier, even if insurances cover a transplant. They don't always cover post-transplant medications, so that can be an implicit barrier. 24/7 phone access. Internet was generally not required. Unfortunately, no one is excluding anyone from therapy for lack of English literacy, though we did want to ask that. And then I want to talk about, so I mentioned when we were looking at the timelines, I mentioned that many of these therapies now increasingly are being offered outpatient. This is a really amazing advancement to keep patients out of the hospital, reduce their risks of infection, and just keep people mobile, keep people moving, keep people from losing a lot of muscle mass while they're in a hospital bed, if we can. And so we asked centers whether they offered therapy as all outpatient, and if so, whether these logistical requirements, including caregiver requirements, were more stringent when this therapy was all outpatient. And I don't think that would probably surprise this group of folks in the audience to know that caregivers are providing a lot of the economic support that allows home care to happen. That this is a huge gap that is making care better for patients by relying on caregiver support, these daily appointments for transfusions, doing a lot of these things. So unsurprisingly, the majority of centers across all 3 types of modality had more stringent logistical requirements if therapy was done all outpatient. So a huge benefit that outpatient therapy is allowing. And then lastly, standardization. So this was one of the recommendations from NAC, and I just want to talk about this because I think this is key to understanding the national landscape and then actually making change. So 63% of centers track reasons for eligibility across all modalities. So almost 40% are not. And eligibility assessments vary quite a bit with both formal and informal at the majority of centers. And what this means is essentially most places have a checklist, right? You must have a caregiver, you must have local housing, you must have X, Y, or Z. And there's also informal criteria, like, if someone has a history of drug use, for example, there can be sometimes essentially soft contraindications or soft requirements around this. Or let's say if the inpatient requirements, like we talked about, if someone has a caregiver, but that caregiver can't do some of these physical tasks, sometimes there's soft contraindication or case-by-case adjudication that allows people to stay inpatient for longer or allows for extra supports for these people. And I think I think it's helpful. I think it's good to know that this is the national landscape. I do want to highlight that informal requirements, and this is something that we were concerned about, informal requirements, case-by-case use, can lead to inequity in how these things are adjudicated because who we make an exception for can sometimes be subject to physician bias. And so this is something that I think is a thing that we need to highlight about standardization and that recommendation from NAC about making this standardized nationally. Lastly, I know I've kind of talked a lot about the survey, but we asked these leaders, physician, nursing, administrative leaders from these different centers to share what they perceive to be the top 3 barriers by modality. And you can see why we're having this discussion today. You can see why NAC is important to this work and why caregivers are so central to the conversation. Caregivers were the #1 barriers that were identified across each modality, with local housing covering for costs, other caregiving duties, so like parenting, for example, of the patient or of the caregiver, and insurance coverage also being huge requirements that centers identified. And so as we think about these requirements and we think about where to go from here, I want to highlight some work that is not my work in any way and is in fact the work of some of the folks who are attending this seminar today, which is this concept of reimagining caregiving. And I'll just speak briefly about this. Sue is going to talk about the exceptional supports that BMT, InfoNet, and others have used to support caregivers and make this easier. I think one really critical thing is to say, how do we improve the requirements, right? How do we make sure what we're offering and requiring is absolutely what's necessary by both standardizing these nationally and by supporting caregivers and patients in other ways when a caregiver isn't available. So this is a collaboration of several national groups and funded by PCORI, in which, if you think back to that slide of what are the caregivers doing, all of these different tasks, how might we disaggregate some of these and say, if there's not a family caregiver who can do this, oftentimes unpaid for 100 days, how can transplant teams and transplant systems pick up some of the slack here? Meal prep, fever monitoring, for example, we have remote temperature tracking badges that are increasingly being kind of getting ready to be used in a clinical setting. How might we disaggregate and reimagine some of these requirements to make these therapies accessible to people who don't have a caregiver or whose caregivers need a break? And so in conclusion, I'll say caregivers are extremely important to transplant and CAR-T. And if I haven't convinced you about the economic value in particular that caregivers are offering, I honestly don't know what more I could say, because caregivers are offering so much support to our patients and making these therapies possible. The current criteria, supports, and processes for assessing caregiver status and supporting caregivers are not standardized nationally. And I think that's what our survey finds. And then lastly, I'll say that national efforts are ongoing to improve access and supports for allogeneic transplant. And I hope that in the future, we'll be able to start similar for autologous transplant and CAR-T or TCRs, these engineered T-cell therapies. So I'd like to end by thanking the vast team of people who made this research possible, and of course to NAC for inviting me to speak today. So I'd like to thank my study co-authors, the NCCN Best Practices Committee, the pilot institutions and survey respondents who made the survey possible, my fellowship program, and in particular, the Anderson family who have funded my research in memory of their daughter, Joanna, who died of sarcoma, and in the hopes of improving therapy and improving care access for patients nationally, including for stem cell transplant. So thank you so much.
Thank you so much, Hannah. This was an amazing presentation. Thank you for sharing your valuable insights. Now I would like to introduce our second speaker, Susan K. Stewart. She's the founder and executive director of BMT InfoNet, a not-for-profit patient advocacy organization that provides information and support services to patients undergoing bone marrow stem cell or CAR-T cell therapy and their loved ones. She founded BMT InfoNet in 1990 following her bone marrow transplant for acute myeloid leukemia. Today, the organization serves more than 20,000 clients worldwide and is a leading source of reliable information and peer support through programs like Caring Connections and celebrating a second chance at life survivorship symposium. Susan is the author of 4 widely used books in English and Spanish for patients and care partners, and she's received multiple national awards for her work on behalf of the transplant and CAR-T community. She has also served on numerous national and international advisory boards, providing patient and caregiver perspective. Susan, thank you for all the amazing work you've done, and thank you for joining us today. We're looking forward to your insights.
Well, thank you very much. I appreciate that. So some of what I'm going to say may be a bit duplicative of what Hannah said, but maybe fleshing it out in a slightly different way. So BMT InfoNet, who are we? We're an advocacy organization for bone marrow, stem cell, and CAR-T cell recipients and their loved ones. And since 1990, we've helped an estimated 300,000 plus patients and caregivers navigate bone marrow stem cell transplant or CAR-T cell therapy. And our mission is very simple. We want to try to empower patients and their care partners with credible information and support services so that they can take a more active role in decisions affecting their health and treatment options. So first, let's talk about hematopoietic stem cell transplant, also known as bone marrow or stem cell transplant. And as Hannah talked about, this is a treatment option for some patients, not all, who are diagnosed with blood cancers like leukemia, lymphoma, or multiple myeloma, some other blood disorders like severe aplastic anemia, genetic or inherited disorders like thalassemia or sickle cell disease, some immune deficiency diseases like SCID, and also some autoimmune diseases like multiple sclerosis. Hematopoietic stem cell transplant is the same as bone marrow transplant or stem cell transplant, at least in terms of how we describe it today. Bone marrow transplant technically refers to a transplant using bone marrow harvested from, or stem cells harvested from the bone marrow, whereas stem cell transplant technically refers to a transplant that uses cells that were moved from the bone marrow into the bloodstream and collected there. In general, a hematopoietic cell transplant is a much more intense and riskier procedure than standard chemotherapy for the same disease. So there's two main types of transplant, allogeneic, also called allo. There's about 9,000 of those done in 2024. And as Hannah said, the stem cells are provided by either a related or an unrelated donor. The procedure relies on high-dose chemotherapy, sometimes with radiation, plus the donor immune cells to destroy the patient's disease. And it provides a new donor immune system for the patients. Autologous, on the other hand, is more common in the United States. There were about 12,000 done in 2024. And in this procedure, the stem cells are provided by the patient, and it relies strictly on the high-dose chemotherapy and/or radiation given to the patient to destroy disease. The stem cells rescue the patients from the lethal effects of high-dose chemotherapy or radiation, because not only does that high-dose chemotherapy or radiation target cancer cells, it can also target blood-forming stem cells. So it's a stem cell rescue as opposed to actually a transplant, but it's commonly referred to as a transplant. So some of the key differences between auto and allo transplant. The auto transplant has fewer side effects than allo transplant, although those certainly are not zero. The recovery is typically 30 to 60 days, and often it's performed in an outpatient clinic. Whereas for an allo transplant, they're typically hospitalized for at least 2 and up to 4 or more weeks. The recovery takes more than 3 months and sometimes very much longer. It has more potential short and long-term side effects, which lead to more restrictions on activities of the patient and therefore on the caregiver. And the care partner responsibilities are significantly greater than those for an auto transplant caregiver. And in this particular type of transplant, caregiver partner or care partner burnout is quite common. So what are some of the stressors for transplant care partners? Well, one, of course, is extended time off work, which can lead to loss of income. They may need to relocate to another city or state for 3 or more months, which involves creating dual support systems both at home and in the new location. They're providing medical care that's normally provided by nurses, often with very little training. And they're juggling both the patient's needs and those of other family members concurrently, which over several months can become quite taxing. And for most care partners, it's very hard for them to find time for self-care. When you talk about the importance of self-care with caregivers, they roll their eyes like you're crazy. You know, where am I going to find time to do this? It's very hard for them to carve out time for that unless there's a crisis. And in many cases, there's a role reversal. They're going from, if they're a married couple or a partnership couple, going from a co-equal partners spouse relationship to a patient caregiver relationship, which causes all kinds of problems both for the patient and the care partner in terms of the expectations and what they think they should be doing for each other. And friends and extended family often really don't get it. They don't understand what a transplant is. They expect when you come home from the hospital, it's like coming home from surgery. You come home, you got a few days of recovery, and you're back to normal. And particularly for those caregivers and patients who are looking at protracted recovery periods due to complications, the friends and family support can tend to wane. And then if they're out of town, they may have a very poor support system, which makes it difficult to navigate the transplant and the rigors of the transplant. So care partner training does vary considerably among transplant centers. It may include one-on-one discussions with a nurse and or social worker. Some patients talk about, or some caregivers rather talk about getting a huge binder of information, which does cover a lot of topics, but could just be simply overwhelming and not as helpful as they would like. And some offer a caregiver class or sometimes multiple caregiver classes, although I think this is less common than some of the other two modalities. Often what it does not include is repetition to reinforce concepts. So I often have transplant centers ask me, what is the best time to talk with caregivers about X or talk to caregivers about Y? And it's really not a one-time process. They need to understand at the outset what's expected, and then throughout the entire process, the transplant team really needs to be touching base with caregivers to reinforce those concepts, remind them of those concepts, so that when they're ready to really process that information, they're getting the information at that time. It often does not include access to peer support. Many transplant centers do refer people to us or to other peer support programs, but many transplant centers do not, particularly for the caregiver. It may or may not include access to professional psychosocial support. So at some transplant centers, caregivers are included in those that can get psychosocial support during transplant, but it does not include that. And oftentimes it includes nothing to help caregivers with stress management. So typically the care partner's role during the first 30 days is this. If the patient is an inpatient patient, the medical team's providing around-the-clock care, so the care partner provides primarily emotional support and reports symptoms as they see them to the care team. If the patient is outpatient, it's the care partner who's providing around-the-clock care when the patient is not at the clinic during the day. Caregiver has to schedule visits, transport the patient to the outpatient clinic daily or weekly. They are expected to monitor the patient for infection, symptoms of organ damage, and other side effects. They're expected to procure and administer numerous medications, which can be quite complex. There are many medications the patients have, and they have to be administered in a certain order and not at the same time as certain other medications. So it really takes a spreadsheet to figure out what you're supposed to be doing when. They're also expected to provide a safe environment for patients, particularly while they're immunocompromised, and then they're providing emotional support, although they themselves may not be getting much in the way of emotional support. During the 30 to 100 days after transplant, this is a period of time when patients who have gone through an allogeneic transplant have been discharged from the hospital, and they're now having daily to weekly visits at the follow-up clinic through day 100. During this time now, the care partner is going to assume many more nursing duties at home, again, for which he or she may or may not be prepared. They have little time for self-care, and they have a waning support system. As the days go longer, support from outside family members and friends can get less. And rehospitalization is often needed if a symptom or a problem arises after transplant, and this can be quite stressful. Whereas for patients that have gone through an autologous transplant, the clinic visits typically end by day 30, and they're discharged to community healthcare providers for follow-up care. Many of those community healthcare providers have little or no experience in managing transplant patients, and sometimes coordination of care with the transplant team can be an issue. After day 100 for the allogeneic transplant patient, ongoing monitoring for relapse, there's ongoing monitoring relapse for side effects, often by the local healthcare provider. There's an issue with graft versus host disease, which I'll talk about in a minute. This is a complication unique to allogeneic transplants. Patients are typically chronically fatigued and may have cognitive issues for many, many months after transplant. They have the caregiver has ongoing stress and fatigue, and studies have found that in some cases, the fatigue and the stress experienced by the caregiver is actually greater than that or equal to that experienced by the patient. Again, they have limited self-care. There's anxieties about relapse, and there's such significant distress that burnout is very common, particularly if the care is continuing for more than 3 months after transplant. Whereas with autotransplant patients, many can go back to work or their usual activities by this point. There is ongoing monitoring for relapse or late side effects by the local healthcare provider. And some patients will go on maintenance therapy in order to secure their remission, which may require ongoing caregiving by the care partner. These patients, too, may be chronically fatigued for many months and may need some help with common daily tasks of daily living. So chronic graft versus host disease is a very serious side effect of an allogeneic transplant. And as Hannah explained, what happens here is that the donor cells that have been infused into the patient look around the patient and say, I don't recognize these cells and these organs that I'm looking at. I've been trained to recognize what belongs in the donor's body, and that's not what I'm seeing in the patient's body. And so the donor's immune system cells attack the patient's organs and tissues, and literally they can attack just about any organ and tissue. Typically, you see it on the skin, the joints, connective tissues, the mouth and GI tract, the lungs, the liver, the genitals, and sometimes the nerves. This condition can last for months or for years. It can be mild, moderate, or severe, and it's potentially life-threatening. The treatment for this condition is usually steroids, which typically last 3 to 5 years, and for about 15% of patients, last even longer. Steroids, as you probably know, increases the risk of infection because you're suppressing the immune system. So there's an increased period where the caregiver has to be careful about exposing the patient to infectious food, infectious environments, etc. It changes body image, what can really create anxiety for the patient, and that can be difficult for the caregiver to manage. And they also can create mild to severe mood swings, which in some cases, and these are the extreme cases, but in some cases lead the patient to become suicidal, which is very difficult for the caregiver to deal with. I remember a story about a woman having the suicidal husband and having to send her children to different homes because she wasn't sure what was going to happen. It was a very, very difficult situation. And it extends caregiver duties much longer than they expected, which increases both their physical and their emotional stress and can often lead to burnout. So let's talk about CAR-T cell therapy. What is CAR-T cell therapy? As Hannah told you, it's a type of immunotherapy that modifies the patient's T cells, which are a type of immune system cell, to help them better detect and destroy cancer cells. Currently, FDA has approved treatment with CAR-T cells for relapsed or refractory diseases, including large B-cell lymphomas, follicular lymphoma, and mantle cell lymphoma. Also, for some leukemias, chronic lymphocytic leukemia, small lymphocytic leukemia, and B-cell acute lymphoblastic leukemia, and also for multiple myeloma. Clinical trials are currently underway to evaluate whether CAR-T cell therapy is helpful for other diseases, such as autoimmune diseases or solid tumors, or helpful earlier in the course of treatment for patients with lymphomas, leukemias, and multiple myeloma. So the steps involved once the patient has been examined and it's been ascertained that they are qualified for CAR-T cell therapy, there's a collection of the stem cell transplant or stem cells, collection of the T cells from the patients, which takes 4 to 5 or 3 to 5 hours, after which the cells are sent to a facility to convert them into T cells. While they're waiting for the T cells to be converted into CAR-T cells, chemotherapy may be needed to control for the disease while waiting for the return of the CAR-T cells, and this can be over a 2 to 4 week period. Once the CAR-T cells are returned to the CAR-T center, CAR-T cell therapy actually begins, which typically involves about 3 days of chemotherapy and 1 to 2 weeks in the hospital. And I have this asterisk because part of this time at some centers may be on an outpatient basis. And then you're monitoring patients for toxicities for approximately 10 to 17 days. After that, for the next 30 days, you're carefully monitoring the patient for toxicities and whether or not they're responding to treatment, whether or not it's actually appearing to cure the patient of their disease. And then long term, you're monitoring them, you're transitioning them back home, and their care is coordinated with their local healthcare physician, hopefully in tandem and in cooperation with the CAR-T cell therapy team. So cytokine release syndrome is one of the first and major complications of CAR-T cell therapy. Cytokines are proteins that are released into the body when the CAR-T cells attack the cancer cells, and this cascade of cytokines can cause various serious health problems. This can begin within a few hours, a few days, or many weeks after CAR-T cell infusion. And symptoms commonly include things like fever, chills, muscle aches, joint aches, headache, loss of appetite, severe fatigue, low oxygen, low blood pressure, low difficulty breathing, and some organ injury. In most cases, these can be managed with supportive care, like adding fluids and oxygen, but in some cases, the patient needs to go to the ICU in order to be managed. The neurological problems, also called ICANS, are inflammation of the nervous system, and these usually occur 5 to 10 days after CAR-T cell infusion, but can also occur later. And the symptoms commonly are confusion, trouble speaking or writing, tremors, sleepiness, agitation, seizures, and brain swelling. It can often look like the patient is having a stroke, which can be very frightening to observe, but usually these symptoms are fully reversible. Other toxicities that people worry about are an increased risk of infection, chronic fatigue, which can persist for months and occasionally years. Many CAR-T patients report cognitive decline, which means they're less able to do as easily tasks that they did before CAR-T cell therapy, and the caregiver needs to fill in the blanks. Anxiety, depression, and post-traumatic stress syndrome are common and can persist in about 20% of patients at 6 months. And then there's fear of relapse, because for most patients, CAR-T is not a curative. It adds years to their life, but most patients, less than 50%, are going to actually be cured by CAR-T cell therapy. So the care partner responsibilities in CAR-T include scheduling and coordinating transportation to the clinic and specialist visits. And of note, the patients undergoing CAR-T cannot drive for 8 weeks after they receive those CAR-T cells. Infection prevention is one of the caregiver duties. You have to have a safe home, free from things that could cause infection, and follow a food safety plan. You have to limit social interactions with people that may be potentially infectious. And you have to acquire and dispense medications, again, complex medications for a period of time. And then you have to monitor and promptly report side effects and provide the patient with emotional support. So in short summary, allotransplant versus autotransplant versus CAR-T. Allotransplant has the highest risk of complications, but also can be curative. Autotransplant and CAR-T have a lower risk. They're curative for some, but only life-extending for others. Caregivers are needed longer for allotransplant than for auto or CAR-T, and care partner training varies considerably. It may be quite inadequate in order for caregivers to feel like they're prepared to meet the requirements. Care partner psychological stress is often greater than or equal to the patient's, and support for partners can wane. Some people don't get it, particularly long term. Although care partners do, in many cases, find silver linings and growth as a result of being a care partner. So just briefly, I want to summarize some of the resources that are available to care partners through BMT InfoNet. We have a peer support program called Caring Connections that links patients and care partners with trained mentors who have been through transplant or CAR-T. We can match the pair by the type of therapy, the diagnosis, age, status, i.e. married, single, or children at home, and other criteria that the care partner specifies. And the connection is typically done by phone. Oops, sorry. We also have online support groups. They're facilitated by licensed mental health providers. They're provided over Zoom. And we currently have groups for patients and care partners who are living with chronic graft-versus-host disease, CAR T-cell patients, and we also have a bereavement group. We have a directory of mental health providers who have been screened, so we're sure that they have experience. Hang on, let me get something to drink. We're sure they have experience with transplant, GVHD, and CAR-T. And I think this patient summarized it well. I learned as a transplant recipient that a therapist is not a therapist. Working with a therapist who understands stem cell transplant is a completely different animal than working with an excellent therapist who doesn't have that knowledge base. I didn't have to explain the transplant experience. We could hit the ground running with our therapy. We also have patient handbooks that explain for caregivers and patients what to expect through the various therapies. And we have an annual survivorship symposium that talk in depth about managing various complications after transplant or CAR-T. Videos from those are housed in a video learning library, so patients can access those if they have questions. And then we have caregiver and care patient stories on our website that can be shared. Finally, we do have a patient assistance fund and resource directory that allow patients to access help both financially and information-wise. And with that, I'll stop. Happy to take any questions.
Thank you so much, Susan and Dr. Abrams, for your great presentations and information. We have just a few minutes for questions, and I'll get us get the ball rolling. I did see a question from Yaslin, and this was directed to you, Dr. Hannah, during your presentation. She wanted to know if you can share what a rotating caregiver is.
Yeah, thank you for clarifying that.
Mhm.
Rotating caregivers refer to when, like for example, in a given 24 hours, one caregiver starts the day and then another caregiver is allowed to take over. So, let's say, or for example, even for some number of weeks. So let's say one caregiver can only get 2 weeks off of work. In centers that allow a rotating caregiver, what that means is that one person can take 2 weeks off of work to travel to whatever city the transplant or the therapy is happening in and take care of someone full time, and then another person is allowed to rotate in after.
Thank you for providing that response. And I just want to chime in that this is particularly, I would say, an important topic for families who share caregiving roles due to cultural or family preferences or situations where it may be impossible due to work or school responsibilities for one person to take off 30 days or 100 days. And think about those family caregivers who have those benefits through work versus those who don't. So I just wanted to chime in and mention that very quickly. I don't see any other questions in the chat. And so I will pull in the one that I prepared for you both. And it's from each of your perspectives, can you share a little bit more about how healthcare systems are currently assessing or providing caregiver support with the multiple tasks and responsibilities. Both of your slides talk about some of the needs and what's required, but I'm interested more in kind of what are the things that you see are being provided very well, or perhaps what are the things that healthcare systems are really missing the mark and may need to step up. So we'll start with you, Dr. Abrams, and then we'll turn it over to Susan.
Yeah, I think my takeaway from the survey that we did is that it is not very standardized nationally, and that there's not kind of national best practices around even how to screen, how to record that information. Oftentimes these are pretty informal conversations that happen during appointments, especially intake appointments or intake consultations. And that's a pretty overwhelming time. So I think many people know this experience of telling someone kind of almost offhandedly. Some people are told, oh, you're going to need a caregiver for 100 days. Then people kind of tend to double take and be like, wait, what? If they haven't been warned. And so oftentimes this is happening somewhat informally during appointments, the screening, do you have a caregiver, do you not? And I think it is not very well standardized nationally.
Gotcha. Thank you. And Susan, if you can briefly share kind of from your perspective, anything else that you want to highlight in terms of what healthcare systems might be doing to assess and provide support, or again, on the flip side of it, what are some of the real big gaps that you see?
Well, from my experience, I think that what transplant centers and CAR-T cell centers focus on is educating the caregiver about what he or she needs to do to take care of the patient. They're less good or less often educating the caregiver about what they need to do to take care of themselves in order to be a good caregiver for the patient. Oftentimes, they do not have support systems for the caregiver, whereas they do have support systems for the patient. Oftentimes, they're not checking in with the caregiver to see how he or she is doing. And as a result, the patient is being supportive, but the caregiver is not getting the same level of support, can't replenish themselves, and be better prepared to support the patient.
Thank you for that. That's reminding me of one of our steering committee members and family caregiver advocate, that they need the support to sustain themselves. And that's what's really missing for so many family caregivers. So thank you so much. With that, I'm going to turn it over to Melina to close us out. And I want to thank you both for your great presentations. And she's going to take care of closing us out and some logistical announcements. Over to you, Melina.
Thank you. And thank you again, Hannah and Susan. So I want to take a moment to thank our sponsors. None of this work would be possible without all of the amazing cancer caregiving, transplant caregiving sponsors that we have. And a few quick notes, we'll be sending out the recording and slides in the next few days, so please watch out for that email. Our next peer learning session will be in July, and we hope to see you guys there. If you subscribe to our newsletter, or you can send us emails, you can find out more information. And finally, please take a moment to complete the exit survey. It will pop up when you exit the webinar. Your feedback will help us improve these sessions. Thank you all again for joining us today, for your engagement, and for your commitment to supporting family caregivers. And take care. We really hope to see you soon.